Yeah, so afternoon, everyone. Thank you for inviting me. Thank you, Fiona, for that very kind introduction as well. I think coming in, sitting in this room is very nostalgic. I think it's like Dickens would have said it was the best of times, it was the worst of times, as a registrar. So, and very thankful to be back amongst friends and family. So, I hope you enjoy it. I thought a little bit, why do I want to come and tell you about tuberculosis mycobacteria? And I thought to myself, instead of just, putting a lot of international articles in front of you, also share a little bit what is happening locally with local data and what can I offer you, as a microbiologist, as a TB specialist in your microbiology infectious diseases field for further testing and susceptibility testing as well. So, it's titled Common Yet Commonly Overlooked. I think, they're really hidden in plain sight and they're very difficult sometimes to identify as disease causing. So with that said, hopefully I leave you with some new perspectives and when you go home to think a little bit about these non-tuberculous mycobacteria. So just as a general overview, hopefully I can show you some cases where I can illustrate that NTMs are really pathogenic in certain instances and they can really be destructive and disease causing. Also show you some diagnostic strategies that we can use locally to identify them in the laboratory, and also indicate to you that they, in our national algorithms, they can fall through the cracks since we're very dedicated towards identifying bacteria and tuberculosis. Then show you a little bit what I can offer in terms of susceptibility testing. And then finally, and I think importantly, also show you some pragmatic solutions and future direction in the Western Cape. I write a lot of my research with Professor Ismail Ali, and I think he tends to ground me a lot sometimes, just saying, this is very interesting, it's theoretically possible, but pragmatically coming back, how would we actually implement it in the trenches, where you guys are taking grenades as well. So I've always start with this article. I think it's one of my all-time favorite articles, definitely in my top 5. And this was written by Prof. Rinian. So for you guys who are not familiar about Prof. Rinian, so we still use his classification in the laboratory with the fast and the slow growers. And in the not so far distant past, he wrote this article in the 1960s. And he says there, these more recently recognized pathogens lack accepted names, and the diseases they produce also are sadly anonymous. This is a situation exceedingly uncomfortable alike for the bacteriologist, clinician, and patient. The latter undoubtedly may suffer psychological trauma on learning that he is afflicted with a disease so new and rare and poorly understood that it is without a name. One patient is reported to have left his hospital against medical advice and committed suicide. The clinician is confronted with problems of treatment, quarantine, and of eligibility of tuberculosis compensation benefits. Here is fascinating organisms to study as to origin, relationship, and control. The occurrence is not so rare. And I think even today, almost 80 odd years later, they're still very fascinating to study and to identify. Today we know there's more than 200 of them, and yearly they're also growing with new molecular identification techniques. So I always like to look a little bit at etiology and naming practices as well. And here I grew a Mycobacterium gordonii with this beautiful pigmentation that happened in the dark. So this organism is grown in algae media or in the dark. And I always sit and think to myself, when I work with them on the benches, if this NTM should have had a personality, how would he or she have been? I think this gordonii would have been very relaxed, laid-back type of mycobacteria as well, but truly beautifully to work with. So we know some of them are scotochromogenic, scoto obviously meaning darkness, and the chroma pigmentation, and genic obviously offspring or formation. And it's believed that these pigmentation in the dark can also play a role in their virulence and antioxidant potential. That's perfect. So what are NTMs? Well, they're non-tuberculous mycobacteria that's acid-fast staining. They differ from the Mycobacterium tuberculosis and the Mycobacterium leprae groups, and they can cause pulmonary and extrapulmonary disease, very much as with Mycobacterium tuberculosis complex. And here you have the Zeal-Nielsen stain showing the acid-fast bacilli. And the typical question is, can NTM show cording? And the answer is definitely. So there's a lot of literature showing that NTMs like NTB complex can also cord, and vice versa. So why should we know about them? Well, globally, NTM infections are rising due to increased immunosuppression in patients, or patients' populations are aging, but we also have better diagnostics, and we also have a better clinical awareness of them. Some studies shows that NTM infections, especially from pulmonary sites, can have high rates of relapse, and almost in a quarter of them, they're culturing the same NTM repeatedly. Here, rates can differ depending on what NTM you work with, so it can be very good, like Mycobacterium malmutse, which is 90%, whereas organisms like Mycobacterium abscessus, commonly more pathogenic, could be much lower, 40 to 50%. Systematic reviews are showing us that 5-year all-cause mortality is also very high with NTMs if not treated effectively, up until 30%. And in an interesting study that looked at some of the data in sub-Saharan Africa, showed amongst HIV positive individuals that was autopsies done, where they initially identified Mycobacterium tuberculosis as the cause of death. 1 in every 7 of those was actually misidentified as a non-tuberculosis mycobacteria. So in terms of the risk factors, especially for pulmonary disease, the typical structural lung diseases, cystic fibrosis, COPD, lung malignancies, those are commonly associated as risk factors amongst patients with NTMs. Especially in the younger generations and children, we know that if we look at primary immunodeficiency, we also get in some of those patients the Mendelian susceptibility to mycobacterial disease. So especially in children that has recurrent NTM infections, that is something that we could consider. We're not sure yet what the impact of COVID-19 will be. I think the results are still coming up in the publications. Needless to say, the post-TB lung is also a risk factor for NTM disease. And then, because they are ambiguous in the environment, soil, water exposure, both natural and man-made, is risk factors for them. This is where occupation and hobbies becomes important. NTMs are a very strong zoonotic disease as well. So they don't have the typical human-to-human transmission patterns as we would find with MTB complex. And zoonosis plays an important role there, as well as we don't sure what the impact of drought conditions will be. We are well aware of that infectious diseases is impacted by climate change and warmer conditions as well, as is NTM, non-tuberculous mycobacteria. And the articles are showing that a lot of these complexes, or the Mycobacterium avium complex, can also form biofilms in these water systems as well. So this is a picture of one of my co-supervisors, Prof. Corson. I think I introduced him to you. So Prof. Corson is the One Health Director at the University of Free State, also sitting with a Sachik chair, and they are doing their research in wildlife. So on the big 5 as well as some other domestic animals. It's always very difficult, I guess, to follow his presentations because he would show a sexy picture of a leopard there and how they would test it in the Kruger National Park, having a lab within Sifusa as well. I think he was recently nominated for an NRF Oscar Award with papers where they do this microbial safari and look for NTB complex and water sources in various areas. And hopefully he'll come and present to you guys in the near future. And that would be also very interesting to look at, but also to showcase the zoonotic potential of these NTMs. So this is a slide that is maybe a little bit tedious, but just to get everyone on the same page of how we identify them from pulmonary disease sites. So you must fulfill this criteria. There must be constitutional pulmonary symptoms, and then also radiological changes. Number 2, you need to exclude an appropriate differential diagnosis. Now, this is a little bit more tricky because the guidelines is not very clear in terms of what does that actually entail. Is that just a sputum MCMS? Does it include a full viral panel? Should we be excluding atypical organisms? So COVID as well. So the guidance is not clear how extensive that should be, and it creates a caveat because can you ever have a co-infection if you have another infection present in the lungs? And then the important one is the microbiology criteria for me. So that could be 2 positive cultures collected 1 week apart and culturing the same NTM. So although we have a 2 sputum method in the Western Cape, so culturing the same NTM on the same day does not fulfill that criteria. So there was a recent study in the International Journal of Infectious Diseases that showed that even if you can't fulfill the radiological criteria, or you don't have an exclusion diagnosis, you still have a positive predictive value of 86% if you can fulfill the microbiology criteria alone. Alternatively to the microbiology criteria number 1, you can also do number 2, which is 1 sample from a more invasive specimen like a PAL, or number 3, when you have a sputum sample but have histology with confirmation of NTM, granulomas, etc. So you need the chest X-ray and symptoms, you have to exclude other infections, and also fulfill the microbiology. So this is to help you distinguish colonization from infection. So by convention, if it's from a sterile site, then it's clinically in keeping. The doctor is suspecting meningitis or septic arthritis. 1 sample in those instances could be significantly in keeping. So this is a study that a case report that me and Terry wrote up, was it last year, I think, with Candy involved as well. It's a patient that was treated by infectious diseases a couple of years ago here and cultured the Mycobacterium simiae. So simiae being from a rhesus monkey, I think initially identified in India. And they are exclusively found in the environment, is the simiae. So there's no cases of human to human transmission. And I think a patient presented with acute and chronic sinusitis also had that in figure A, you can see that very prominent proptosis and then severe bone erosion as well in the sinuses. And unfortunately, the isolate was not stored for any further molecular investigation, but subsequently we did create a biorepository at Greenpoint, where we are now storing all NTMs within the Western Cape. So that includes Ferguson Hospital, Typo Hospital, and Greenpoint. 4 studies like this to investigate them a little bit further. So what nicely is shown by this specific study is just the impact that some of these common environmental NTMs and destructive nature that they can have. So this is the first case with this organism related to sinusitis. And it was a few bacteremias, if I remember Terry correct, on the blood cultures grew a few times, but no pulmonary involvement clear on the chest X-rays. I don't think they did a CT of the chest at that stage. And also sputums did not identify this organism. And then around the sinuses, a lot of the fluid collected there, as well as the biopsies indicating this organism relevance. Looking at sub-Saharan Africa, so there's not a lot of data out on our NTM situation, specifically in South Africa and sub-Saharan Africa. So this article is a little bit old, 2017. Nothing newer in our region, but also showing the 30% belonging to the avian complex, so avian and intercellulare, and still a large proportion, almost 20%, sent out as unidentified to the species level. So looking a little bit closer to the Western Cape, and if we take 2016 to 2022 into consideration, remember track care came into play in 2016, and in 2023 we changed our line probe assays to the XDR cartridges. So taking that into consideration, we see that our main organisms above 2/3 is still Mycobacterium avium complex, so avium and intercellulare. So this is done from line probe assays, and as the registrars will know, there's some caveats to that as well. So the line probe assays can't distinguish Massidense and Comeria and some of the other subspecies as well. And then following that, we see a lot of unidentified species, Tensacea and Fortuitum. Now, interesting enough, just looking at the sputum samples, in more than 50% of those cases, there was no second confirmation sample that could show that NTM the second time around. And from that group, almost half of them, a second sample was never submitted to the laboratory. Also interestingly enough, with that NTM, there was almost a 13% co-infection or potential co-infection with NTP complex occurring at the same time. So to put that a little bit into context of what we are signing up to microbiologists from the laboratory. So this is the same doctor, so it's not name and shame, but just to show you the same organism, same doctor, and reported quite differently as well. And I think the main message here should be highlighted or appearing first, that we need that second sample. So if you look at the bottom, more or less at the bottom of those messages, send a repeat sample only comes out quite late. And we know clinicians in TB healthcare workers overburdened in clinics does not have the time to read these messages. So can we maybe find a better way to translate these laboratory results back into clinical medicine? So then if we look at the extrapulmonary sites, we can see the incidence of our NTMs per population. This is 100,000 per 100,000 did increase, more or less during our COVID peaks as well. So maybe there was a bit more consciousness regarding respiratory disease during that time. But as services normalized, we're seeing that the peaks coming down. Extrapulmonary specimen site-wise, we're still seeing a lot of bacteremia blood culture NTMs. And from those, more than 80% being mycobacteria avium. So this beautiful picture here from a bone sample was taken by one of my colleagues there at Greenport Lab, one of the hematologists. And I think you all can appreciate that predominance of organism present. So in this specific patient, from the pulmonary site and bloodstream, they could culture the mycobacterium avium as well. And just to highlight, a positive urinary lab doesn't always just conclusively indicate NTB complex, but NTMs can also be positive in those cases. And then finally, just to show you there, looking at individual-wise, mycobacterium avium having a higher odds ratio compared to intercellulare, when HIV 1 year old cause mortality is present. Almost as would be expected, extrapulmonary disease also has a higher 1 year old cause mortality compared to pulmonary disease. And then Mycobacterium cancacea, when we compare extrapulmonary versus pulmonary, also had a higher chance of 1 year old cause death. Maybe indicating for that specific NTM, we should maybe be a little bit more wary for a rightful weight approach compared to some of our other NTMs in management. And then finally, when it comes to recurrent NTM cases, as in keeping with the literature, more than 80% of the time, it was Mycobacterium avium complex. So just one word about co-infections, which I think NTB complex NTM, which is a hot topic these days, a lot of publications going out on that. A recent publication at the end of 2025 did show that if you have the co-infection with NTB complex and NTMs, there's a higher chance of mortality compared to the individual groups by themselves. And especially when they stratify it to the elderly age groups above 65 in that specific article. This is something that all the microbiologists, in fact, anyone in this room should take note of. And this is a national change. It's the targeted next generation sequencing, the duplex that's being done on all the antigen resistant cases. And this is an effort to get results quicker compared to the normal phenotypic ways of getting the vernacular contaminant. And what duplex could also do that you may be not aware of, it can identify co-infections, like in this case. So you see that it looks at the heat shock protein. Oh, sorry. So just at use the arrow. Yeah. Yeah. So it looks at the heat shock protein, which is a common marker for NTM identification as well. And you can see here it indicates to us if there's co-infection. So when the NTB complex is mixed with an NTM potentially present. In those instances, it won't give you a susceptibility result, but it can tell you that both are present. And there's some other nifty things that the duplex can also do, maybe not reported to the clinicians. It's that's the typing. It can tell you also what lineage is involved, etc., especially if you're considering outbreak from cases. Then I just want to mention something about children quickly, not elaborate too much on that. Needless to say, NTMs amongst children is very rare compared to adults, much less. In this specific case, it was less than 5%. And most of the children actually don't get a second specimen submitted. Most likely the clinician felt there was an alternative diagnosis with a viral present, or they were just thinking and convinced that it's potentially a contaminant in the specific child and clinically improving. Still a lot of unidentified species with the children that we are sending out. And then we see a lot of mycobacterium abscessus within the topula. So in this case, it was a trend, it was not statistically significant. Whereas we see a lot of intercellular in all the types of individuals, but it's less common in the toddler group compared to the earlier adolescents as well. So it seems like different ATMs is preference in terms of different age groups, but this will need a little bit more investigation. Now, my slides are not broken here. I guess I always include this in my presentations when it comes to NTMs. And they are like finding a black cat in a dark room, especially when it comes to our algorithms. So they are not a diagnosis by exclusion, and we specifically need to look for them with this common mycobacteria and additional species line probe assays. So the line probe assays is a DNA hybridization type of assay on a neutralized membrane. The CMs can identify 27 species, A's can identify additional species, LPA can identify another 19. I did mention to you already that we have more than 200 of them currently still growing, and we are still sending out quite a few unidentified species as well, even from sterile sites. So for the microbiologist again, when we're reading these line probe assays, for those of you that have seen the banding patterns before, you will notice that there's a lot of bands there, and there's not one of the banding patterns within the manufacturer's guidelines that will correlate with that. We're not allowed to send out mixed cultures, so you're not allowed to identify two NTMs on these line probe assays. And in this case, and this was a while ago, I think in 2023, we took that isolate and then we China sequenced it, and we found Mycobacterium septicum. So Sanger sequencing is a very cost-effective, very easy way of identifying these unidentified mycobacteria species. We'll start with conventional PCR in the left-hand top-hand corner there, include genes like the HEAT-CHOP gene and RPOP, and then we send them to the Sanger Institute. So it's very local here at Tigerbird, at Stellenbosch, the Central Analytic Facility, and it's very cost-effective. So it's not and it's a very short gene to sequence as well, about 700 base pairs. You get the results back, and you get this chromatogram that you see on the right-hand corner, and you can use that to sort of identify if your sample is clean or not. There's not mixed peaks that's in there. And then finally, with a freely available online system, you can blast that. So you put that trimmed little sequence that you can do yourself into this database. And it gives you a percentage identification as well as coverage of the gene as well. So this is a very cost-effective, easy way to identify a lot of these unknown species, especially if you encounter it in a clinical setting. And this is something that we can do for you locally as well. Then me and Ali and a few other co-authors wrote this article, a perspective article, and really challenging a little bit of these old dogmas that we're dealing with. So the previous international criteria was sent out in the early 2000s, I think, and in 20 years later, 2 decades later, they sent another updated version out. But the diagnostic criteria very much stayed the same, even after 20 years. And although we have quite a big increase on our molecular capability to identify these organisms. So we were saying, why do you need the second culture if you can use a molecular test to identify the second culture? Because that's all what it really does. It helps you identify the clinical resonance of your first culture, which can also go for susceptibility testing if needed. So we were challenging that dogma a little bit and giving some updated guidelines or recommendations of how we can incorporate molecular testing to immediately identify that second specimen for us. And then I got hold of a CM direct test. So all of the CM and ACE line probe assays that we do, as the microbiologists would know, we do from clinical cultures. But there's certain CM directs which can be done directly from the sputum sample, although it's not available in the NHS domain yet. So that gives us the opportunity to, if you already have your first culture confirmed, for us on the second sputum sample, doing it directly from the sputum sample and in a day or two confirming your identification of the organism. It's a great rule and test, but obviously in most of the ciliary cases, we still want the culture and CMMA as LPA. And we found about a prevalence of 1.7%. And if you look at the local literature, that's more or less where the prevalence of NTMs falls, somewhere between 2 to 3 to 5%. So then we wanted to do a bit more deeper sequencing on these unidentified species, especially the midget tubes that we found. So we did Oxford Nanopore technology deep sequencing on them. I think we included about 28 isolates. If I remember correctly, they were majority from sterile extrapulmonary sites as well. And we found some interesting observations. The first one being that those samples were quite mixed. So it's not just one NTM that we identified. There was a few of them coming together. So the question is, why do they want to occur together in groups like this? 14% was unidentified that in our curated database from all the sequences that's available from NTMs, 14% of them we could not identify against that. Potentially novel species, most of them on phylogenetic analysis being fast growing. We found that almost 50% included mycobacteria monaxense. And monaxense, if you go look at the literature, there's quite a few case series up on them from various extrapulmonary sites showing their clinical relevance. And this is all cases from the Western Cape. Then also, if we compare the ONT sequencing or Sanger sequencing, we identified an agreement of about 70% for the predominant species. Multi-top, so matrix proteomic studies, not very useful when you have mixed cultures. So still probably needing pure qualities for the identification. And then we also did the duplex, so the technique that I showed you previously as well. And that was unable to identify co-infections in minor subpopulations. So whenever the MTB complex falls below 3%, it seems like the duplex, as per the manufacturer, can't detect that MTB complex. Now, the biggest question, I guess, to ask here from a clinical perspective is what is the relevance of this? At what percentage must an organism be present, especially if it's mixed, for you to target it? And no one really knows that answer at this stage. Should it be 5%? Should it be 10%? When should we start taking that specific organism into account when we are treating these patients? So this is just a picture of the Oxford Nanopore technology and the course that's running there. Then I thought this could be very interesting for the microbiologists, especially. Just to remember, although there's a lot of novel molecular tests available there, you can still rely on the old phenotypic identification methods. And that table clearly is showing with the biochemical reactions how you can distinguish different NTMs from one another. So the reason I mentioned that is I want to take you to another interesting observation that we found. So this was a patient that had a sputum sample, and on the line probe assay we found this band. So a 7, a 9, and a 14. So I already told you we're not allowed to identify mixtures from these line probe assays. And for those of you that has worked with it, will notice a 9 is intercellularic, and a 7 and a 14 belongs to the fortuitum group. So I applied a little bit of these old methods because we have the media lab right next to us. And I asked them to make algae media for me, but to add 5% sodium chloride, so to add salt. I still remember having to carry the eggs to them because they didn't have the eggs to make the algae media. Because they baked them and they add the melanite that gives that nice green color and everything. So we add we plated out that midget on the salt containing algae media that you see on the left hand side here, so number C going down. And then also I knew that intercellularic can grow and withstand very high temperatures. So I incubated it at more than 45 degrees Celsius. And then finally, when I got growth, I repeated the line probe assays. And long and behold, there we got fortuitum and intercellularic out. So But this patient had 2 previous sputum lesion cultures as well, which only showed the intercellular, only the band 9. And when I applied the same methodology to those 2 samples, I got the fortuitum out also. So that shows us that the line probe SS is probably not identifying both organisms, and most likely the most prominent one. And also makes you think a little about what happens in terms of interactions within that tube. Does the one organism utilize the nutrients a little bit better? Does the one produce toxins that inhibits the other one's growth? So we're looking a little bit into that study as well with some filtration techniques. So when it comes to having these co-infections, I think a pragmatic approach would probably be to identify the MTB complex as we do with the EBNR tests. But at the same time, you will have to apply some sort of line probe assay to identify the NTM as well. So the CM and the AS. And when you get to the bottom there, and you say, well, if I find both of them, what should I do now? So if you look at the international criteria, they do mention them, but there's no clinical trials on it. So no one has clear guidelines in terms of how you should manage it now. Should you first manage the MTB complex and later on the NTM? Do you manage them both at the same time? And I think talking to a bit of pulmonologists and infectious disease specialists, it boils down to either having the watchful wait approach and see if the patient on culture converts while treating the MTB complex first. But in certain cases, anecdotally speaking on a case-by-case basis, if there is severe immunosuppression or there's severe lung cavity destructions, or you have a more pathogenic organism like the Cansacea or the abscesses, you can maybe target both of them. You add your cornerstone drug like a macrolide if you get through the macroorganisms as well. So talking about that mycobacterium on that sense there, we got 8 of them viable, and we wanted to take a little bit first at them because they were in the majority of our isolates from these unidentified species, almost 50% of them contained it. So we found 2 clusters, one here in the Cape Metropole area and one more centered to the center of Peru. And they were clonal, both of those clusters, and they were quite far apart in terms of SNPs, almost 8,000. So that phylogenetic tree just showing you that it's 2 very distinct type of clusters far from apart, and they're clonal as well. And interesting enough, the one group contained plasmids, because remember, MTB complex in membrane does not have a plasmid though, whereas NTMs do. They can share it amongst each other in the environment. So one of those groups had plasmids with them, and the other one had special genes on the chromosome. So the one group was able, with these CD4 genes, to in intercellular niches to acquire iron in a CD4 way, and the other group was able to survive more oxidative environments with their genes, like you would find in the granuloma. So in addition to that, we also did the microdilution type of plates. Remember, there's no real breakpoints for these NTMs, and we extrapolate a lot. We also did the NTM DRLPA, so that's the line probe assay that you will do at the NICD on a case-by-case basis, but that only looks at the aminoglycosides and the macrolides. We did whole genome sequencing, and then we did the proportional method with the critical concentrations that we will also be here for rifampicin and INH. And I think what we found was between the whole genome sequencing virulence and resistome genes, it was a lot of discrepancy when it comes to the phenotypic results that we got as well. So we do need better curated, comprehensive databases to link that with one another. The plasmodome, like most NTMs, will probably play a big role in environmental adaptability and how they would react in a host as well. And then also, when we look at current treatments, when we were doing the susceptibility testing, you'll see that most of the drugs at least will have, like in river form, will have partial coverage of this specific NTM, and most likely to other NTMs as well. So if you treat a patient with river and there's a co-infection with the NTM, it looks like at least it will get some partial coverage from that. So that is the NTM DRLP I was talking about. So that's the one done at the NICD when you send it up. Only validated for certain few organisms. and only for the macrolides and the aminoglycosides. But we know MAC is the most prominent ETM, and we need that as the premisin as the cornerstone drug there. Then we do the proportional method with the critical concentrations. The big caveat there is that we don't know what the critical concentration should be for ETM. So we extrapolate again from NTP complex. Like most of these cases, we are extrapolating. And the new one I'm doing here is the MIC plates that we have. Again, the caveat being that we don't have breakpoints for them. So even if we get an MIC, it can give us an idea it's very high, very low, but we don't always have that clear breakpoints. Yeah, so that's the microdilution plates that we see there. I don't want to go too much into treatment. That's maybe a little bit beyond the scope of this presentation. But when we look at the less common identified NTMs, not the Gordonias and some of the other similes, etc., the level of evidence for their treatment remains low. And in the blue, it's very, very finely written. I think fine print. It's almost like they want to hide it from you as well there. But they say there that, for example, an organism like M. gordonii, you need overwhelming evidence that this organism is causing invasive pulmonary disease. If treatment is necessary, DST can be performed, although no standard treatment can be recommended, and they give you a few options that can follow. So there's definitely a case-by-case basis, bit of anecdotal evidence that is also needed when treating these very less frequently isolated NTMs. We are seeing with refractory cases, so those are NTMs that's treated, that's not culture converting, that you've treated at least for 6 months on the correct regimen, with not just empirically, but with susceptibility results, and the patient is not culture converting. We are seeing some of the repurposed drugs being used for that as well, like teploplastin, like imidaquilin, that's also starting to creep into the regimens in those selected cases. And then, last but not least, in terms of treatment, is bacteriophages. I think everyone that's heard me talk has probably in some way mentioning bacteriophages before as well. The TASK team, just next door, across the road there at Tygerberg, they have a dedicated team now that's implementing and looking at phages for mycobacteria species, not just NTMs, but MTP complex as well. So I think that's a very promising field. I think it will need a lot of bold investment from private funders, also a lot of open-mindedness from an ethical perspective as well, and then from the microbiologists, food manufacturing practices, when we ever get to that point of using it as adjunct therapy to any antibiotics. This is a very interesting case that I think that I thought was worth mentioning. It's a patient that was seen at DP Marais locally. And I wrote this paper with Janet and with Dr. Croxford. It was a patient with progressive multifocal encephalopathy, and he presented with mixed NTM infections. So, not to get you too lost, on multiple sputum samples, he cultured Mycobacterium cancellari. He had a single culture of Mycobacterium chelonia, and we know that from sputum that's not enough. And then also from a blood culture, you do a Mycobacterium avium. So when we did the Sanger sequencing with the heat shock gene, so ASP65, we got 100% Mycobacterium cancellari. And when we implemented the duplex, that's also using the heat shock protein, we got 100% avium, and this is from a sputum sample. And unfortunately, the blood sample was not available for us. We just had a sputum meter. You said, how can this be? Did we make a mistake somewhere? And when we took a sputum sample and we multiplexed it with multiple markers, the RPOB and the heat shock, we found both of them. And if you go look closely at the primer design for these two individual platforms, you'll see that they have different affinity. So even though they're targeting the same gene, one primer design platform has a higher affinity for the avium, while the other one has a higher affinity for the cancellari. So the line professor we know can fail to detect NTM cascades, and most likely we will have to use multiplexing different targets if we want to identify NTMs in some of these samples as well. But when it comes to treatment in mixtures, it will be done on a personalized basis, where we know can satiize with the rifamycin component. I think they added rifamycin here. For the MAP isolates, we know we want the macrolide or the azithromycin. So you will end up in a scenario where you will cherry pick some drugs to cover most of the organisms if found clinically relevant in those cases. This is a study I did with one of my special SSM student modules, what's at the third year elective students in medicine. And we wanted to look at something that has come up in the past. So for those of you that was in practice before that ultra, so the gene expert before the ultra version was present, there we still had the 5 probes, I think, and you looked at delta, CT, and probe fallout. There was cross-reactivity with some of the MTMs. So mycobacteria intercellulare came up in some instances as MTP complex. We know with the new version, we have the insertion segments that gives the test a lot of sensitivity. And what we did is we wanted to test this new version again. So we had a panel there of NTMs and then also a panel of common respirators, but these some of them common respiratory tract infections, both gram-positive and gram-negative. And what we found was, not surprisingly, insertion segments didn't come up with the bacteria or the gram-positive, gram-negative bacteria. But when we looked at the RPO gene, we found remnants with the NTMs, which you would also suspect. And it made me think a little bit what Prof. Tron from the Klein group said, he said, are we mining our data adequately enough? Because this is data that we already have available. So if you have that patient that gets repeated gene experts, it's repeatedly negative for the insertion segments, but the sister tells you that there's radiological symptoms, radiological signs, there's constitutional symptoms. So by just looking at the data and seeing that the RPOB signals are coming up positive, is that a soft sign for us to maybe think about, is this a potential NTM that we're looking at? It's just a bit of food for thought. I mean, it needs a lot more investigation, but it's data that we already have available and that we can look at. Then also coming back to some SSM students, Prof. Wilson always says, don't think bigger, think smaller. We want to teach people about NTMs and we want to bend the trees while they're still very young. And I don't think you must underestimate the advantage or the potential of investing in these young medical students. It's going to be walking these halls as medical doctors, as registrars in the very near future. So we always get some students that we bring over to us, and together with Stellenbosch University at the BMRI and UCT, we get very nifty, very cool little projects on NTMs that we can do with them. And in the process, also teach them, hopefully them spreading the good word one day when they're both more senior as well. So I think this is a call out to all of you, sitting here, having to get involved in SSM students. I do feel there's value in investing in these young doctors. Then something that will be on your inboxes in the very near future is a questionnaire that we're sending out. It's going to be a national questionnaire. It's approved by the NHLS. It's a knowledge, attitudes, and perspective. And we want to know a little bit, what do our technologists, our registrars, our pathologists know about NTMs in the lab? Because like Prof. Brim used to say, if you can't measure it, you can't treasure it. If you don't know where the problem is, how are we supposed to fix it? And there's 5 domains. We are looking at their diagnostic knowledge, their confidence, and their competency in identifying these organisms. Do they feel that we are training them really? Do they feel like we have the right resources? And do they think we are making the right communication to the doctors and the health workers as well? So if that comes into your inbox, please spend a few minutes and help us get that information. Then I have to leave you with something cool as well, right? So this is me next to a nucleomagnetic resonance instrument here at Upper Campus at the chemistry building. And what we're basically doing is we're trying to find a fingerprint for NTMs in our mixtures. So if you look at that image there at the top side, you'll see that is, so NMR tells you about the aminoglycosides, the fatty acids, the carbohydrates, all the elements that's in the media that you're using, so metabolomically wise. And we're trying to find a fingerprint, so unique signals that comes up with certain NTMs or even when they're in a mixture as well. And we've seen a lot of this being, not a lot, but recently done papers where they do it with TB as well. So you're trying to find a unique fingerprint where you can sort of identify them also. Do I think it will ever be implemented in the NHLS? Definitely not. But it was still very cool to do, and I got a bit of funding for that from Mary Gosling. Convince somebody there. And just wrapping up, I think we need to think about downstream applications as well. So for the microbiologist that's done the scheme in the AS micro assays, you will know that we use Genolyze. So that's the Bruker hand product that we use, and it gives almost a yellow tinge color to the extracted DNA. So now we get that. It works wonderfully for the line probe assays. But what else can you use this DNA extraction for? Can you do sinus sequencing? Can you do TNGS with it? Can you do other whole genome sequencing? Because the DNA is actually very dirty. If you go look at the absorptions, different ratios, there's a lot of protein still in it, etc. So we investigated that a little bit and we found, well, it still works very well, very cheap, very effective for sinus sequencing, which I can help you with, obviously, which is a good thing. But just to be open-minded that even systems that's in place, can it really be implemented with newer platforms that we are implementing? And then something that me and Ali is also thinking about is this NTM Elite agar, which is a selective media for NTMs. It's specifically made for cystic fibrosis patients. You don't need to decontaminate the sputum. It's just 100 microliters onto the plate. It's made by Bionomere. Very expensive, unfortunately, not available yet in South Africa. Because at this stage, when you treat an NTM patient, you want to see radiological clinical improvement. And then you want to see culture conversion. But there's nothing in between. It's either you culture converted or you did not. And you'll see that some international studies and institutions is using these colony-forming units for monitoring prognosis. So is the colony-forming count actually coming down? So it gives you an objective way to see if the patient is responding to treatment. So I've been working with that as well a little bit. Then I heard a little bird sing. I won't say beyond this room. Is there a new cartridge being developed for NTMs? So Cepheid, we have the XDR cartridge, we have the Ultra. We're meeting again next week with people from Stanford and Johns Hopkins, and it will be interesting to see what type of targets they would choose in these cartridges. But so that's something to look out for on the horizon. If most of the microbiologists, or that's on the wider TV groups, would be aware of this. So that is the Roche Cobas instrument. So that's present at Greenpoint Laboratory. So you are using the BD Max here at Curtis-Ski, and the peripheral labs mostly using the Genix Ultra. And there's been a global alert that's been sent out now, where the BD Max, or sorry, the Roche Cobas, is detecting specifically Mycobacterium Campsaceae in complex. And this is from the cultured isolate. So if your culture counts goes very high, so above 10 to the power of 6, the Roche is making a mistake in potentially cross-reactivity and calling that Campsaceae as Mycobacterium tuberculosis complex. So we are mitigating this because we are aware of it. So all our positive cultures is being run on the Gene Expert. So only the raw sputum specimens is run on the Roche Cobas. We know our prevalence of NTMs is very low, and we know the amount of acid-fast bacilli in the sputum is also very low, not above 10 to the power of 6, which you will find with typical cultured midgets as well. So just something to take note of. I did hear from other institutions up country that they also found that some other NTMs is also having similar problem, not just Campsaceae, but the global alert was sent out for this specific NTM. So I think in conclusion, these organisms are ambiguous in the environment, and they're sometimes very challenging to distinguish between colonization and true infection as well. Although our local infrastructure and our national health priorities is aimed at NTB complex, I think as the NHLS, we must be adapting and we must be open-minded towards emerging and opportunistic diseases. Things like new plates that we can introduce in the laboratory, like the NTM Elite agar plates, that can produce actionable and measurable clinical outcomes for the clinicians and so forth. And then finally, we need to speak a language that is understandable both from the laboratory and the clinics as well. So we need to look at how we're reporting our results and avoid some of the jargon and overfill reports that we send out, and that the clear message is translated back into clinical practice as well. So with that said, always be on the lookout for our WSP training at Greenpoint. So me and Sir Vishnu, we have some courses for our technician technologists, and we present this to them in a very cool, fun, interactive way. You can come and learn a little bit about TB and NTMs. And then always our doors are open for lab visits. So some of you that's already been there, I know Tara, you've been there as well. Maybe one of the Friday meetings, come to our lab and we'll give you a tour and show you our high-free TB laboratory. Let's go through a bit through the algorithms as well. So yeah, the office stands. Thank you very much.